I'm Dr. Patrick Burns. I'm a family physician with St. Elizabeth Physicians in Covington. As far as the change in processes that we've sort of taken on with CPCI and the patient-centered medical home process has been basically to try to get lab work done before the patient comes into the office. The reason for that is then we have it in front of us when the patient is here sitting on the exam table, and we can really, I think, make a much better intervention and make the changes where patients more clearly understand what we're trying to accomplish. We can do a better job of teaching them, and then I just think we get better buy-in when we do that. Through our EMR system, I'm able to send a message to my healthcare advocate or another team member to follow up with that patient in a period of time, let's say in 5 days or 7 days, to see what their blood pressure is doing with the changes, see what their sugars have done since we've made those changes. I think that hands-on team approach, a more intimate contact, really gets buy-in. I think the patients understand that we really value controlling their disease processes, that we're trying to prevent long-term complications of these conditions. And I think just the they perceive that the energy that we're devoting to the process gives it some credibility of the need to take care of it.
Hi, my name is Dr. Delene Mushalak. I'm an internal medicine pediatric physician at St. Elizabeth Physicians. Today I'm just talking about how CPCI is affecting our clinic here. It's been a really good experience. One thing about primary care that I feel is important is that primary care is a frontline medicine, and we're in charge of coordinating all of our patients' care and making sure that they get to the appropriate physicians when needed. One way that CPCI has helped us is that we have care coordinators such as the healthcare advocates or the HCAs who help us to follow the patients in between office visits. In addition, another thing I feel that CPCI has helped is for us to keep closer contact with patients and not only make a difference at the office visits, but also during their daily life. One specific example I have is a patient who's a truck driver, and he had to get what's called a DOT exam in order to be able to drive his truck. He has diabetes, and he was found to be uncontrolled. His diabetic number was about 11, which is almost twice as where we want it to be. In order for him to drive, he can be on insulin but needed an exemption, but he really refused to do the exemption. So what I did was I got him connected with the HCA who works with me, and we worked with him on oral diabetic medications, and he was able to get his number down to 7, and now he's driving his truck without any insulin. I feel that the program of CPCI is helping to build relationships between physicians and patients. The importance of it is that a physician needs to build a good rapport with all of their patients in order to build trust and reliability. Because if you get a patient who's healthy and all of a sudden they get diagnosed with breast cancer or diabetes, they'll trust you more in order with your decisions if you have that rapport.
I'm Megan, and I am the front office assistant for Dr. Burns' team care for St. Elizabeth Physicians in Covington. Kind of my role is to pre-visit plan to get things ready for Dr. Burns and for Debbie, the medical assistant, before they do get in with the patient, to give them kind of a heads up of what is coming in, and also to give them more time with the patient when they are in. I kind of used this sheet, which I did start with patient-centered medical home, and at that point it only had 14 things that we were looking for, including hemoglobin, LDL, monofilament, and eye exam, which also gives me the ability to call patients if they had labs ordered at their last office visit, and make sure that they've either got those done or plan on getting those done before the visit. So as far as pre-visit planning, it is helpful because it gives the patient more time with the physician and able to talk about what they actually were coming in for.
Hi, my name's Mickey. I'm a healthcare advocate, licensed practical nurse. I come in and I just really find out what the patient's in need of. Resources, financial, medication, transportation, see where they're at, understanding their disease process so that we have the understanding of their knowledge on it, because I think knowledge is power, but if they don't understand what it is, that's where miscommunication can happen. And I educate them. For an example, if they want to stop smoking, we walk through smoke and sensation on the important things of why you need to quit and resources they can have for support or medications and the difference of the patch and the gum and the oral medication. So it's just a lot of education and one-on-one. I think the most important part of my job, however, is being able to treat the patient holistically. A lot of patients want to do the treatment, but there's barriers in their life, family, friends, spiritual, and being able to sit down with them and really talk to them to find out what's going on in their life and expressing that to the physician. It's just wonderful because it's going through the whole team of where this patient's at.
My name is Christina, and I work for St. Elizabeth Physicians in Covington, and I'm a front office assistant. My daily task for my physician that I work for is Dr. Patterson, and I am in charge of doing all of his diabetes checks and in control of looking up what they need the last time that they had a monofilament or an A1C, and my job is to make sure that certain patients get it every 6 months or every 3 months or within a year. That way the physician's numbers are high and the patients are getting what they need. Also, we need to check mammograms for women, their PAPs and everything. We need to make sure they're within a year. If they're abnormal, we have to check things like that. And that's normally the pre-visit planning that we deal with to make sure the physician's ready to see the patient in the morning. And then afterwards, we always call our patients to check up on them, to see how they're doing, to make sure that they know they're being taken care of, and that's kind of our main job, and just to make sure that we're giving them everything they need and taking care of them. Better for them to come in here and see our physicians eye to eye instead of having to keep sending them to the hospital. So they're not going there and have to see different people. They need to come here so we can focus on treating them and getting them the proper care that they need. And then we send them now to our health advocates also. We follow up with them to make sure that everything's going good and have them give us a call if they need anything.
So my name's Brittany. I'm a health advocate nurse at St. Elizabeth Physicians in Covington, primary care. So before CPCI, there was no funding to bring in additional help like a health advocate, which is what I do. I bring in patients and I educate them about their disease process, or I help them get the resources they need to control their disease process, such as medications or finding the financial resources for medications. Getting transportation to their doctor's appointment. People don't understand their disease process, so how do they treat it if they don't know? So I provide resources. I put together packets for each disease process I deal with that has the most hospitalizations. Again, diabetes, HF, COPD, pneumonia, heart attack patients after they've already talked to our care transitions team. So I put folders together that are, generally friendly for a 5th grade level and above. It's got anything they would want to know. This is for diabetes, for example. It has a card in here that says the tests that they should be getting annually, the blood sugars ranging, what they should be if they're fasting or if it's after a meal, what their blood pressure should be at. It talks about low blood sugars and high blood sugars and how to treat it, the risks of diabetes. So anything they'd want to know, even dietary, it's all in here. I also came up with a paper that tells them what they should be doing daily for CHF, and I have that for each one of my disease processes. So daily weights, watching their sodium intake, fluid intake, monitor their breathing, checking for swelling and taking their medication. And again, has zone management, so they know if they're green, they're good, they're yellow, they need to let us know, and if they're red, they need to go to the hospital. And I also have created diabetes classes because that's been the #1 problem that I have with patients is controlling their diabetes, because that's the gateway disease. It doesn't just affect your blood sugars, it affects everything, your kidneys, your heart, everything. So we do a diabetes class once a month. It's on a Saturday in the afternoon. We have a certified diabetes educator that comes, as well as home delivered diabetes meal. They bring samples, and people get education that they might not have had or have the opportunity because they can't afford the specialty doctors, or maybe they had it already and they don't remember. It was 10 years ago. So it's a refresher and it's additional education for patients that might not have had it otherwise. So it's all about resources, and then following the patient monthly, knowing that you're there for them if they need anything. They know they can call you and they don't have to worry about getting an automated system. They have a person at the end of the line that they know will answer or leave a voicemail and they'll call you back. So it's gaining that trust and a relationship, knowing that the person you're calling actually cares and can help you. And I don't think that was there before CPCI. So my job is to keep them out of the hospital
and they know to call me if they need anything, or if they have a question. Instead of just going to the ER, they can call me and be like, hey, we can get you in for an appointment. One patient I've worked with in particular, it took me months to get a hold of her, but I did my monthly call and finally was able to get her on the phone after calling family members that were on her HIPAA, and they relayed the message. Found out that she didn't have health insurance, and that's why she hadn't been coming to our office, and she hadn't been able to get her medications in a few months. And when she had about 4 heart attacks by the time she was 44, and her last hospitalization, they told her that if she didn't take her Plavix, it could kill her for not taking it. So with the help of Dr. Patterson and I coming up with samples that could cover the medication she was on here at the office, and then also finding some resources online, such as a website called GoodRx where she could get coupons, she was able to get all her medications. And about a month later, she called me back, and she called me her hero and said because of what I did, she's able to be on all her medications. She finally feels like herself again, and actually referenced the website I gave to her mother as well, and so she's able to get her medications. So it wasn't just impacting her as our patient, but she paid it forward, and her mom, who wasn't our patient, actually benefited as well.
As part of the preventative care, when the patient comes in, I discuss with them the things that they need, their health maintenance, their immunizations, and I just basically give them a heads up if they have not already had it done. And then I put it in the computer system so the doctor can come in and discuss it with them in more detail about the testing or immunizations that they need to have done. Prior to the PCMH and CPCI, we didn't really do the preventative care like that. And now before the patient comes in, we know exactly what they need and what needs to be done. And the patient, hears it from me, and then the patient, Dr. Burns, comes in, or the doctor comes in and discusses that with them. So they get to hear it from several people before they make a decision, so they have time to think about what they need to have done.
One of the questions that frequently comes up with CPCI and patient-centered medical home is, what outcomes are we seeing through these changes we made? And while we're very early in the process, I think it's really quite exciting. I think on the most basic level, I think a good example is what we measure in terms of quality scores. And in our particular practice, we have 15 measures that we look at every month. And even though I considered this practice to be a very, very strong practice from a quality care point of view, in 2012, December 2012, of those 15 measures across the entire office, we actually were not up to the standard of national metrics on any one of those 15. And that's really not unusual until a practice starts the changes necessary for CPCI and patient-centered medical home. And now, 18 months later, we are exceeding the metrics in 10 of the 15 measures. Another level has to do with ER utilization. This is a relatively new thing that we're looking at, but over the last 3 quarters, we've seen a 16% decline in our Medicare patients who end up in the emergency room. And we think that has a lot to do with just many of the practices we've adopted, both on a system level, but also at an office level, at trying to meet the patient's needs, again, proactively. Any patient that's discharged from the hospital is seen back in our practice within 1 to 3 days. That's to make sure they understand what the discharge instructions were, make sure they got their medications filled, make sure their condition is definitely improving. Another way that we've intervened on emergency room utilization is we identify frequent utilizers of the emergency room. We actually contact them by phone as a practice and see what it is that drives them to the emergency room. Is it access to our office? Is it transportation issues? Is it a financial issue? And again, we try to come up with ways to break down those barriers to utilizing the primary care office as their first contact. And I'm real excited that we see this 16% reduction, because that is a significant improvement in healthcare spending.